let me start by a quick introduction. I will tell you, Dr. Hamburg, who's joined us tonight as the guest, has really one of the most extraordinary resumes. I guess I knew most of these things, but not all of them. And just it really is extraordinary. She's been the commissioner of the Food and Drug Administration. She's come off most recently as the Foreign Secretary of the National Academy of Medicine. Her interim part-time job is as the Vice President for Global Biological Policies and Programs at the Nuclear Threat Initiative. And before that, she's had other very senior roles in government, the Assistant Secretary for Planning and Evaluation at the Department of Health and Human Services during the Clinton administration. She was the Health Commissioner of the City of New York, which is, I believe, when we first met, which was a few years ago when Mayor Dinkins was there. And was also the Assistant Director of the National Institute of Allergy and Infectious Diseases. She's on multiple boards, but relevant particularly to the discussions we've had the last couple of weeks. She's on the board of Gavi, the Global Alliance for Vaccines and Immunization, and as the chair, she's not on the board, but she's on the chair of one of the governing bodies of the entity, the Coalition for Epidemics Preparedness Initiative, CEPI. That was remember when Dr. Gellin spoke to us about CEPI's role in helping support the development of vaccines for the global community. So, I think Dr. Hamburg is one of in my experience, one of the leaders in public health in our country and in the world. Like I said, her career is extraordinary. She has an amazing ability to make the very complex seem very understandable. And whether she's talking about global issues or talking about inner city issues, this breadth of going from our domestic situation to the global is really almost unparalleled. So anyway, we're really excited, Peggy, that you're with us tonight, and we have a terrific class here, young people. So thanks for taking the time. Really appreciate it.
My pleasure. Delighted.
Well, that's great. Well, we start off, I've warned you with this. My first question is, since we are, everyone here who's at least enrolled in the class is an undergrad. And a lot of the reasons people take a class like this is to get a sense of how people like yourself who've been leaders, how you got to where you are today. And so I guess I'd ask you to maybe reflect on what you were thinking when you were an undergrad and give us a little bit of the path that you took with your own career. I think particularly thinking about what made you decide to go into medicine and public health. My guess is you had many options and probably, and given the breadth of your career, many interests as well. So I'd be fascinated if you could give us a little bit of a history of what got you to where you are today. We'd really appreciate it.
Sure. Well, I guess I'm a living example of how sometimes you think you're very focused on what your career path is going to be, and somehow you end up somewhere completely different. That's what happened to me, but it's been enormously gratifying and I have no regrets. I actually grew up on the Stanford campus. I was what was fondly known as a faculty brat, and both my parents were physicians at the Stanford Medical School. So it won't surprise you that I grew up kind of thinking I might go into academic medicine. I arrived at college and actually sort of suddenly realized that there were all kinds of other interesting things that I might do. And I hated my first couple of pre-med classes because everyone was so competitive. So for a brief period, I thought maybe I would go into journalism or law or something else. But I kept finding myself coming back to things that were related to medicine, and decided, to return to what I thought was my career path in academic medicine, where I would teach, I would take care of patients, and I would do research. I thought I would go into probably reproductive endocrinology, maybe neuroendocrinology. And I applied to medical school, with very well-defined interests and essays explaining what this career was going to be. However, during medical school, which was now quite a long time ago, even though in our freshman class in medical school, we were literally taught that the future of medicine was chronic disease because of the advent of antibiotics and vaccines, we started to learn about and see some cases of this unusual immune deficiency syndrome that was happening mainly in young homosexual men, but also in some other populations, in hemophiliacs, in Haitians, and in some intravenous drug users as well. Nobody knew what it was. Nobody knew what was causing it. But what we did know was that people suffered greatly with this immune compromised syndrome, developing all kinds of additional infections and ailments, and it was uniformly fatal ultimately. As I progressed through medical school and then on into my residency training, actually in New York City for my internal medicine residency, we learned that it was caused by a virus, HIV, human immunodeficiency virus. This syndrome was called AIDS. But we still didn't have any drugs to treat it. Yet I watched as this emerging new disease, in fact, a global pandemic, took hold. And of course, New York City was particularly hard hit. And I saw that while we were struggling just to manage these patients and reduce their suffering, that it was causing all kinds of repercussions, social, legal, political, economic. And I started to think about how I wanted to work at the interface of medicine with broader issues, as I also wanted to help work on finding strategies to really manage and maybe even prevent this terrible disease. So I talked to a lot of people about what I could do. That was really when I learned about public health. In medical school, I hadn't even really learned about public health. I knew that there was a school of public health because I went to Harvard Medical School, and the School of Public Health had a better cafeteria, but I didn't know what public health was. And we didn't learn anything about population health, and we really didn't learn much about the broader social context of medical care. So I talked to a lot of people. I ended up going down to Washington, D.C. to learn about health policy and public health. The chair of medicine at New York Hospital Cornell, where I did my residency training, was very upset with me. And he said, if you aren't back in 2 years to do subspecialty training, you will have thrown away your entire career in medicine. He couldn't understand what I was doing. I actually ended up becoming Tony Fauci's special assistant. And he was like my ideal mentor because he was deeply immersed in the science of AIDS, doing bench research, seeing patients and doing clinical trials, trying to develop those very drugs that we didn't have when I was in New York City. Trying to treat these patients and care for them. But he also was working on policy issues, and one of the few people in that era that was really speaking to the public and to policymakers about how serious this disease was and that we couldn't try to marginalize it. We all needed to care and invest in solutions to address it. So I worked for him. Then I went on to go to New York City, where I became health commissioner rather unexpectedly, because I didn't actually have a degree in public health, which was a requirement of the city charter. But I was the acting commissioner after the commissioner left rather abruptly. I'd been recruited as a deputy. And then Mayor Dinkins, took a chance on me, and he actually went to city council and got the charter changed, and used my experience working at NIAID as comparable experience to having a master's in public health. Anyway, one thing led to another after that, but it really was a profound experience to watch this global disease pandemic unfold and to see the gaps in our ability to respond and care for patients, much in the same way that for all of you, I suspect that COVID will be, a seminal experience that has made you rethink a lot of things about your own lives, as well as how you can make a difference in the world, and the career paths that can help you achieve those goals.
Peggy, that's amazing. You know, it's interesting. Our last speaker was Eric Gooseby, who actually also had a similar description of how his path going into medical school and coming out was profoundly shaped again by HIV. And I think you're right. These are historic pivot points.
Mhm.
Let me probe one. I mean, I think it seemed though that you've always been interested in looking at these intersections between health, economics, social justice, the broader issues. I mean, I'd say the other overlay of the last year, in addition to the disparities of people who are impacted by COVID, the people who are most severely affected by the disease if they progress, there are obviously communities of color, people who are marginalized in some way or another. But we also have the overlay of the George Floyd moment and this remarkable, at least in my lifetime, focus. Really, probably not since the 60s or 70s, a focus on racial justice. I guess I'd love your thoughts. Are you hopeful in this moment? Do you think that coming out of AIDS, as horrible as it was, there was an awareness? You could imagine, you can see a greater movement in terms of LGBTQ communities and their awareness and rights, hard fought, of course, over time, but progress. Do you think there's a moment here where are you optimistic looking forward that the collision of race and a pandemic and our culture, our society, that is something going to come out of this and putting us in the right direction?
I guess I'm guardedly optimistic. And some of my optimism stems from what I've witnessed in my own lifetime, watching HIV/AIDS transform from being a uniformly fatal disease to a chronic condition now, where there are people alive today that actually never thought that they would be. I was with a friend the other day who was just turning 68, and I jokingly said, one of the things that's, surprisingly good about being a senior citizen these days is that you can get the COVID vaccine. and he's HIV infected. And he said, well, for me, I am so grateful to be 68 because I never thought I would get here. And, that really affected me, because you forget.
Yep.
But I believe, that we can, harness both science and societal commitment to address important problems. On the race issues, I think it's really, really striking that across many different sectors, there's been this mobilization, this realization about the seriousness of racial injustice and structural racism in this country and in other countries as well, this sort of awakening. The question is, can we hold on to it? And again, going back to my personal life, I might just add, my mother actually was the first African-American woman to be admitted to Vassar College and the first to be admitted to Yale Medical School. And, she really grew up born in the South during Jim Crow. Her family suffered greatly. She lost her father early on. She overcame, a lot of embedded racism, and, became, a very renowned pediatrician and child psychiatrist, tenured at Stanford and at Harvard. But she talked about, how she really did not know whether we'd ever be able as a nation to overcome the history and the prejudices. And although she had Alzheimer's and was suffering quite a bit in terms of memory loss. When I left the FDA, I was invited to do an Oval Office visit with Obama, sort of a farewell. And I decided to bring my mother with me. And I explained beforehand, that a little bit about her background, but also, that she had Alzheimer's. So that, the president sort of was aware, but she was actually amazingly coherent. And just to her, the idea, that a Black man was president was just amazing. So anyway, that just, since you wanted me to personalize a bit, that for me is another reason for optimism. But, we have to recognize that none of this is easy, whether it's addressing, these deeply entrenched problems of racism and disparity and inequity across many dimensions, and the big challenges that are being presented to us in terms of course, the global pandemic we're in the midst of, but also climate change and food and water insecurity and conflict and weapons of mass destruction and terrorism, and our energy futures. All of these things are complicated problems that require complex solutions. They require science and technology to make a difference, yes, but they also require the engagement of the public and society. They require sustained political will and commitment. And of course, they require certain sacrifices for a common good. And, I hope that these overlapping epidemics that we've witnessed with COVID, between the epidemic of an infectious disease overlaid, in fact, on an epidemic of chronic disease that made people more vulnerable, overlaid on longstanding issues of racial disparity, which fueled both the chronic disease and the infectious disease problem, but have many other ramifications as well. My hope is that this awakening and sense of mobilization, galvanization, that we can't let this persist, will endure and be acted on. But there are a lot of reasons to be deeply worried when you look at our political situation, that despite new leadership, the divisiveness and the toxic politics continue. And the sort of what's in it for me attitude, not in my backyard, that also persists. And we know there are hard times ahead in terms of where we are as a country and a world, including an economy that's going to be very hard to come back from. So I'm, as I said, I'm guardedly optimistic, but I think it's some steps forward, some steps back, and I think we can't let down our guard. We can't, sort of hit the snooze button as life comes back a bit more to, a previous familiar pattern, but we have to keep thinking about the magnitude of the challenges and how interconnected we are as a people of this country, but also as global citizens.
Well, thank you for doing that. I was hoping you'd personalize it a little bit, because I do feel like you're, the lens you bring from all the places you've been is really important. I don't think this is a simple moment, but it's a really important one. I can't think of a time when so many things are moving at the same time. They may not all, in the end, we may not end up going where we want to, but it's hard to remember a time in recent history where there's been so many things are shifting so quickly. So let me, before we turn over the students, I want to switch another part of your career, which I think has been fascinating, is you've really been one of the people at the intersection of health and diplomacy, global health diplomacy. How do we think about using the tools of diplomacy and international engagement to improve health? Obviously, the pandemic is sort of one big case study of why it matters. But I think you've worked both in pandemics. You've thought a lot about deliberate threats, accidental threats. How you use the tools of international engagement from government and also from civil society, given all the boards that you're on. So I guess I thought I'd ask before we turn over if you have some reflections on uh, what you think is the power of global health diplomacy, and what is it? What does our agenda need to be right now, both as a country, but I guess more broadly too.
Yeah. Well, there are a couple ways to address that question. I would have to confess that, I am fundamentally a globalist. I do believe, as I just, observed, that we are inextricably intertwined with people around the world. Our health is intertwined, our economies are intertwined, and ultimately our safety and security, prosperity, and quality of life are all intertwined. I believe one can make a very powerful set of arguments, whether it's COVID or other things, that we have a vested interest in this country in caring about the rest of the world because of those interconnections, and that we can't ever just wall ourselves off, and live well and be safe. COVID right now is a perfect example where I think we have an urgent responsibility to help get vaccines to the rest of the world, both because it's the right thing to do from a humanitarian point of view, but also because we will not be able to control the disease in our country if we don't address it in other countries. Doesn't matter if we have more than enough vaccine for every American. If the virus continues to spread and variants continue to emerge as it spreads, then we could be back where we were at the beginning with a virus that is able to elude the protection of the vaccine and prior protection of infection to an earlier variant, and at risk again. So, you can make arguments like that about, why it's in every country's own best interest to invest in global health. But I also think as we look at the world and want it to be a better, safer place, the value of using health programs to address the kind of diplomacy that often happens, with just people sitting at tables with big floral arrangements, negotiating treaties. Health is galvanizing, and health cuts across, nations, across cultures, across religions, across values and history. In almost every national tradition, there's a proverb that reflects on how much health matters. Whether it's without health there is hope, there is no hope, or the Ben Franklin observations about a pound of prevention, what is it?
It's
a penny of prevention is worth a pound.
Yes.
Anyway, I should have brushed up on my
on your aphorisms from Ben Franklin, exactly.
But hope and health are so crucial, and health programs and using health as a tool of diplomacy can bring communities and countries and parts of the world together that are in conflict in so many ways. And we've seen that historically when vaccination programs actually led to what were called days of tranquility, when armed conflict was stopped so that kids could get vaccinated against preventable diseases that might take their lives. We've seen also how actually health and science programs and scientists working with scientists actually were crucial in helping to end the Cold War, when scientists in this country and scientists in the former Soviet Union were actually talking to each other and building communities of trust when the two nations were in the midst of a Cold War. But as soon as those barriers politically started to break down, it was those communities that enabled trust and confidence and collaboration to emerge in ways that I think really laid the foundation for success. And when we look at areas of the world like in the Middle East, where there are countries that are in constant conflict, peoples that sadly have grown up learning not to love each other but to hate each other, they actually share a set of very common health threats, whether it's water safety or foodborne illness or outbreaks of infectious disease. And when you can get them to work together in a collaborative way, it can really make a difference and start to build those bridges, start to create channels of communication. And the organization that was mentioned at the beginning, the Nuclear Threat Initiative, it has a bad name, but one of the things that we did early on, now almost 2 decades ago, was to set up a disease surveillance regional system in the Middle East that brought together the Palestinian Authority, Israel, Jordan, Egypt, helped build capacity and shared training and technical assistance so that they could protect themselves against infectious disease threats. And during COVID, the value of that has been, clearly reinforced. And during COVID now, it's been interesting. The US and Chinese governments clearly are not acting like allies in any way. But again, we really do need each other to solve problems that are before us, from COVID to climate change. And there are communities of physicians and scientists through organizations like another entity where I do a lot of work, the National Academies of Science, Engineering, and Medicine, that we're continuing to talk to each other. We're continuing to learn from each other. We're able to start to clarify some of the questions that have been obscured by political rhetoric. And I think that really makes a difference. So I think we really need, in this modern era, to integrate health, as actually your professor, Professor Monahan, has been doing over many years in his career, to build health and science programs into the work of the State Department, and to really make these kinds of programs that really matter, and matter in a way that's palpable. It's not deferred gratification. It's things that matter every day to people wherever they come from, to build that into how we think about diplomacy and the programs we develop and implement.
Oh, thank you, Peggy. That's that's exactly perfect. Perfect place for me to transition off to some of our excellent students here. So I'm going to start with Erica, and then Lydia, I think, is our. So Erica, do you want to kick us off? And I'd say, please introduce yourself, what year you are, what school you're in, and then pose your
what
question.
time zone you're in.
And what time zone you're in. That's relevant for several of our folks here. So, so Erica, you want to kick us off?
Hi, Dr. Hamburg. My name is Erica. I'm a freshman in the School of Foreign Service at Georgetown, and I'm currently in Fairfax, Virginia, which is Eastern Time. So thank you so much, first of all, for coming in to speak to us. Going off of what you mentioned about the importance of international collaboration and accountability, I believe in a recent NTI seminar, you mentioned the importance of cooperation among scientists and companies in combating the spread of the virus. So I was wondering, how effective will recent partnerships similar to the Johnson & Johnson company with BARDA and Merck be in eliminating the risk of COVID-19? And should there be more pharmaceutical companies be urged to cooperate at this time?
Well, I think that one thing that COVID has absolutely demonstrated is that public-private partnerships are essential to progress. We would not have been able to create a vaccine in the time frame that we did. It was less than 1 year from when the Chinese scientists posted the genome of this new coronavirus, and vaccine was authorized for use in people. Before that, the fastest vaccine was 4 years. That was mumps, and most vaccines were 10 to 12 years. And people like me said with great confidence, there's no way it can be done in a year. Maybe if we're lucky, 18 months, but don't kid yourself. So I was wrong, and science prevailed. But that couldn't have happened without industry and government working closely together to figure out ways to accelerate the development process and making investments that were risky investments, because nobody knew which vaccines would actually make it over the finish line. In fact, if any of them would. I mean, remember that we still don't have a vaccine for HIV/AIDS, but also investing in scaling up and manufacturing vaccines in very large numbers before we knew which vaccines would actually go into use as well. I think that the ability to advance the vaccine development process was aided not just by working across disciplines and sectors, but also working across borders. And I think that should be recognized. It was underdeveloped in terms of the commitment of all nations to making vaccine available. And that's an ongoing issue that you probably talked about, and we can certainly talk about more. But the science that went into developing the vaccines was very much an international undertaking, drawing on the work of scientists from many different countries. And also, I have to put on my FDA hat and say, regulatory authorities around the world work together closely to better align their standards and expectations and guidance, so that companies weren't going to have to do different studies for different regulatory authorities, so that the best regulatory science could be brought to bear on the process, making sure that the critical questions needed for authorization or approval would be asked and answered in the most efficient ways, and that companies also wouldn't have to do, a million different bureaucratic steps for different regulatory authorities. And that really made a difference as well. So I think that without a doubt, it was the coming together of the different stakeholders and partners that has enabled us to move swiftly. And we saw that with HIV/AIDS actually as well. And, interestingly enough, there were a lot of lessons learned during those early days of everybody coming together around the table to shape the research agenda and implement it, including the patient advocates, the AIDS activists. But then some of those lessons were lost. Some persisted, but they've been renewed again, and I hope we can keep those learnings. I think that we really have to now, speaking from the US perspective, really make sure that we don't allow what many call vaccine nationalism to get in the way of what's necessary as, citizens of the world, but also in terms of truly controlling a global pandemic. The Trump administration really did not invest in the global strategies for vaccine access and distribution. Withdrawing from WHO was certainly one aspect of that, but also not being part of. Have you talked about the COVAX facility?
We did talk about it a bit with Bruce, and a little bit with Eric as well.
Yeah,
and there's been some reading on that, so they have some.
Yeah,
background.
so the Trump administration, really wasn't interested in supporting a lot of international organizations or activities. The Biden administration has really made a very significant shift with money going to CEPI and Gavi. They had been supporting Trump had been supporting Gavi through some of the foreign affairs budget, but with respect to COVID-19, renewed investments in those important entities rejoining WHO, and importantly, putting several $billion into the COVAX facility. But we have to make sure that that really continues, so that we make that kind of global activity and strategy successful, and that we not think that the job is done. And there's frankly language that I hear in the daily press conferences or the weekly press conferences coming out of the COVID team now, that sort of suggests that there's light at the end of the tunnel, because by May we're going to have enough vaccine for every American who wants it. That isn't good enough. We need to keep pressing hard until we get vaccine around the world, and that blanket of protection, which is a safety net for us, but a public health necessity for everyone.
Peggy, and I do get a little worried when I hear sort of victory. I mean, it's completely understandable why the new administration wants to focus on the enormous success in ramping up vaccines for Americans. Personally, I'm hoping that when we get to that moment where where adult Americans who want vaccines can get them, that maybe the political moment could change to talk about doing even more globally. That's my personal hope, but I have no inside track on that. Let me turn it to Lydia. I think you're our other.
Yes. Yes. Thank you so much, Dr. Hamburg, for coming to talk to us. I'm Lydia, and I'm a senior in Georgetown College, and I study biochemistry. So my question's like a little bit more on the science side and related to your role at the FDA.
Hey.
When I was watching you talk at the NTI seminar on COVID-19 from January, you mentioned that even though a number of vaccines have now been approved by the FDA as safe and effective in preventing severe cases of COVID, there's still things that we don't know about the vaccine. So whether or not they prevent transmission or mild or asymptomatic cases, as well as whether people of different age groups might mount immune responses differently to different vaccines, especially because the mRNA vaccines are such a new technology. So I was wondering, how do scientists working on vaccine development or the FDA prioritize the continued studies of a vaccine after it's already approved? So like, what do we want to know most about the vaccines now, and why?
Yeah. Well, really an excellent question. I mean, first I have to underscore that in fact, these vaccines are not approved. At FDA, language really matters. So they're authorized under an emergency use authorization, which meant that basically they were assessed on the same standards for safety and efficacy that an approved vaccine would, but it enabled the vaccines to move out more quickly, while the process of actual approval will go forward. But under an emergency use authorization, you also have the tool to really control how the vaccine is used and require additional ongoing studies. And so that's going on as well. It's important to recognize that no matter what, whether it's an emergency or not, whether it's a full approval or an emergency use authorization, you never know as much about a vaccine at the time it goes out into use, or any other medical product, really. When you do the studies to assess safety and efficacy, you're doing it under very controlled conditions. And that's because you want to be able to get critical answers about how the drug works and about its safety profile. So you have, first of all, a limited number of people who enroll in the clinical trials. You usually have a study group and a placebo, and people don't know who's getting what. And you want your populations to be controlled in terms of certain parameters, so you can get clearer sort of fundamental answers, and you don't want a whole bunch of people with a huge spread in age or other drugs that they're taking or other medical conditions they might have, because you want to be able to really hone in on a set of critical questions about how well that particular product works under what conditions. But then, so part of the FDA job really is not just yes, no approval or not. It's also continuing, whether it's an emergency use authorization or a full approval, to study the drug or a vaccine over the course of its lifespan and its real world use. And so you're always collecting more information and doing pharmacovigilance. Sometimes the FDA will actually say you have to do these additional studies, and we will reassess as you get us additional information. On rare occasions, based on that information, FDA might actually take away an approval, but also to learn more about whether there are certain subpopulations the product might work better for, whether the dosing can in fact be adjusted, et cetera. So there's a lot of ongoing study to be done with these vaccines. The pace of the research and development was extraordinary, as noted, and that has been a very important thing. But we have to recognize that there was some knowledge lost in the process. By compressing the clinical trials, we don't know as much about whether the vaccine could be spaced in a longer interval, because people want to get the second dose to people as quickly as possible, 3 weeks for Pfizer, 4 weeks for Moderna. It may be that it's at least as good if it's spaced at 3 months or maybe even longer. A lot of vaccines have a longer space between initial shot and booster. We don't know how long the duration of protection from the vaccinations are. We need to study that and learn more. We don't know whether, in fact, in a crisis like the one we're in the midst of, 1 dose of the 2 doses vaccines might be good enough. We need to study that. And importantly, and I think you touched on this, the studies weren't done in a way to really assess asymptomatic infection and the possibility of spread, even if you don't get sick. The studies were structured to look at impact on severe disease, hospitalization, and death. And all of the vaccines have proven to be very, very effective at that. Interestingly, some people have said, is the J&J vaccine as good as the mRNA vaccines because the efficacy rate when studied was a bit lower. But, you know, that may be partly because the vaccine was studied under different conditions and is a bit of a different vaccine. The J&J is the only vaccine study that actually looked at asymptomatic infection, and it does look as though it's protective against asymptomatic spread. So that's really good news, and that likely holds true for the other vaccines, but the studies are still going on now to find out if that's true. But the J&J vaccine also was done in several different countries, 8 different countries, in fact, including Brazil and South Africa, where there have been these worrisome variants that seem to be able to at least in part elude the benefits of vaccination and immune response to natural infection as well. So their efficacy isn't quite as good because they were testing in a setting where there were these variants, but it also has told us a lot of important information that even though it's not quite as good, it's still good enough. That level of efficacy is substantially higher than what FDA had originally set as its threshold for consideration for authorization or approval. So the studies are all different. The studies don't tell you everything you need to know. More studies are going on, and we need to now be looking at the next generation of vaccines, both to address the variants as well as to address some of the issues that make them harder to manufacture and distribute in large volume. the fact that the mRNA vaccines have to be stored at these very, very cold temperatures, especially the Pfizer, obviously makes it harder for underserved communities, whether in this country or low-income countries in other parts of the world. The one shot is obviously better than the two shot, but we need to learn more. So there, it's an ongoing dynamic process. Sadly, this virus will probably be with us for a very long time, and the science of developing new vaccines as well as new therapeutics will also be an ongoing dynamic process.
Excellent. So let me see other members of the class. People want to jump in? I'm looking for any hands. If no, okay. Oh, there we go. I knew we'd get. So let's start. I guess we got everybody on the top. So why don't I start with Liddy, and then Shushwan.
Hi, my name is Lydia. I'm a senior and I'm studying biology of global health and Chinese. Like Lydia, my question is also related to sort of your experience at the FDA. Obviously, we've seen during COVID that there is an important balance between the need to develop effective vaccines or effective treatments really quickly, while also needing to have a strong foundation in science and data. So in very time-sensitive situations like COVID, from your experience, how has the FDA sort of balance these types of competing priorities, and what sorts of considerations would you take into account during these types of authorization processes?
Yeah, well, every day, either in a crisis or routinely, FDA is always having to balance benefits and risks. No product is entirely safe, no product is 100% effective, and you really have to look at what do we know, what are the other treatment options, how serious is the disease condition. You're willing to take more risk in terms of safety for a life-threatening disease than for a sort of common garden variety headache, for example. But you have to always be balancing risks and benefits, and it's a great challenge. And during a crisis like this, it gets very tempting for people to think that anything has to be better than nothing, and to engage in wishful thinking, and to hope for that magic bullet that's going to turn things around. And I think this was especially challenging for the FDA because of the level of sort of political tension is probably the kind way to say it, but and the media frenzy that surrounded a lot of the work being done. FDA is a science-based public health agency. It has some of the greatest experts in the world on vaccine development, for example. A lot of experience with what works and what doesn't, and really needed to be protected to do their work and to be able to sort of keep their head down and not be brought into the political maelstrom. And we saw, unfortunately, bad decisions being made because of political pressure. And, frankly, an FDA commissioner who was brand new, had never worked with the FDA, had never worked in government before, and facing, the biggest crisis of our times. And, decisions like to make hydroxychloroquine available because the president wanted to believe it worked, even though there wasn't data to support its use and there was known concerns about its safety, was a mistake on the part of FDA. And sadly, FDA's reputation suffered as a result. And FDA's ability to do its job and do it well depends on trust and confidence of the public. And in fact, the ability of the biopharma sector to thrive depends on the trust of the public in the products that go through FDA review and approval. So a very important ecosystem was badly damaged. I think that that Steve Hahn, the then FDA commissioner, worked very hard after a certain point to try to rebuild the reputation, to try to protect the FDA from outside political influences, and to really define the rigorous the rigorous scientific standards
Right.
that would be used, especially for vaccines. But it was a hard period, and I think, you know, we used to talk about at FDA that you know, you had to earn trust every day, and I think that was profoundly demonstrated during COVID. And the other thing that was a lesson I learned while I was at the FDA is that if you are not open and transparent about what you're doing and why, people tend to think the worst and be suspicious and be concerned. And I think there was a lot of worry that this problem of vaccine hesitancy was being worsened by people not understanding the process that the FDA would follow, not having confidence that political intrusion might lead to the authorization of a vaccine that didn't meet scientific standards, and that everything was being accelerated to a point that might put people at risk.
Excellent. So let me turn, I'm going to encourage everybody to make their questions as short as possible.
And I'll try to make my answers shorter.
No, I wasn't going there, but just to keep us moving on. But Shushwant, will you go next? And be sure to remind Dr. Hamburg where you are.
Yeah. Hi. Thank you for speaking with us. My name is Yu Xuan, and I'm currently a sophomore in the School of Nursing and Health Studies. I'm currently in Beijing, which is a very different time zone. So I guess that's really interesting. My question is on the new idea of vaccine diplomacy, because as you mentioned that vaccine nationalism has like an active impact on the global equal like access to vaccines. And I think my question is about what role or like what impact would this new vaccine diplomacy play in this global distribution of vaccinations?
Well, I think it could be really quite powerful, and I hope that the US will think about the opportunity for leadership in this domain as well. You know, we're mainly seeing it coming from China and Russia in terms of making vaccines available to low and middle income countries. But, you know, there are countries that are desperately in need of vaccine and don't have access to it. So it certainly is a welcome mode of engagement, and it can't help but foster positive connections and some sense of obligation to the countries that are making it available. I am curious, you know, I've been watching what's happening in China, and it is interesting to me that the Chinese vaccination program within China doesn't seem to be moving forward as swiftly as I thought it might. At the same time that the Chinese government is making vaccine available to other countries, and that may well be, you know, a reasonable public health decision, because right now cases are very, very low in China, and there are other parts of the world that need vaccine more. And there's a strong argument, although it's a very selfless one, of targeting vaccine to where it will make the most difference in terms of disease control. But it has been surprising to me, given, you know, that China obviously has suffered at the hands of this virus, that there isn't a more aggressive campaign within the borders of China. So it's almost like the opposite of vaccine nationalism in some ways. But I suspect we'll be seeing a lot more vaccinations, and China is an awfully big country, as you know.
Excellent. Shoa?
Hi, Dr. Hamburg. My name is Shoa. I am a sophomore studying global health, and I'm currently outside the lovely city of Philadelphia. My question relates to your experience in navigating politics and diplomacy in healthcare. So in the Global Health Action Agenda for the Biden administration, it was mentioned that the WHO controls only a quarter of their own funds. And we've seen negative consequences of having earmarked and conditional funds, like, for example, the global gag rule. So I wanted to ask, what issues arise when we use our domestic politics to steer international health agendas? And also, do you think that this is in any way a form of neocolonialism?
Well, I think the WHO is a very challenging organization. It represents, I think, something that is enormously important, an organization that brings together countries from all around the world, countries that are rich and poor, north and south, sophisticated and much less mature in terms of medical care, their scientific enterprise, their public health systems, and their economies. But it exists to try to sort of equalize, in many ways, access to knowledge and information, access to programs that work, and to help support distribution of critical drugs and vaccines as well. But it is way underfunded. It's been way underfunded for years. It's also subject to its own set of complex geopolitics and pressures. And it has been over the years, I think, subject, because of its funding constraints, to becoming sort of a patchwork of programs and policies, because people say, I'll give you this money to do this program, and another country says, I'll give you this money to do this program, or a foundation comes in and says, I'll give you money to do this program. There's been lots of talk about how this has been damaging to WHO's ability to fulfill its unique and core functions, and that we really need to find a way to support WHO through sort of guaranteed contributions and a guaranteed budget, and try to really define the unique areas of activity where if WHO doesn't do them, they won't get done, and make sure that they happen, and make sure that countries don't bargain with WHO by withholding resources, etc. But it's I think I have worked either at or with WHO since I was in college. Actually, I took a year off while I was in college to work at WHO, and I actually ended up coming back after 6 months, because I found out that it was such a terrible hierarchy that because I didn't even have an undergraduate degree, even though I'd been recruited to be a research assistant, I was a glorified secretary in an institution that had a secretarial pool system. So people would come up to me and just hand me things to type that I'd never met before. In any case, it's a flawed organization, but it's a really important one. And I hope that even though we've had serious discussions about reform before, that this will be a time when we really look at it, help try to support it, and recognize that it is an entity that can't exist at the whim of the biggest country, the biggest funder, but has to really serve the interests and needs of all countries, and in particular those that don't have the same resources within their own borders.
Well, Peggy, we're a minute over the time you so generously shared with us, and so I think I'm going to have to bring the questions to a close, and just maybe say to you, I don't know if there's any final words you want to leave with our students tonight before we cheer you virtually here by Zoom.
Well, thank you. I apologize that I gave 2 long questions, but in an academic setting, you sort of a little bit of prerogative to lecture. But I think there's never been a more important or exciting time to pursue careers in global health. There are many, many paths you can follow within that sort of rubric of global health. And, all of you taking this course reflect that you can come at it with different backgrounds, different perspectives and experiences, and find things that interest you, things that hopefully arouse a passion and sense of determination to make a difference. I mean, for me, as I mentioned at the beginning, I didn't follow the career path that I had set out on, and I made some decisions about jobs I never thought I would have. I mean, to me, if you had asked me even 6 weeks before I was offered the FDA commissioner job, I would have said not in a million years that job. But the sort of willingness to sort of look at opportunities that come your way when a door opens, not being afraid to go through it and not feel locked in to decisions you'd made before about things you thought you wanted to do. If you discover that there's something else that you're really passionate about and where you think your particular interests and abilities would be better suited, because, I definitely made some changes. I remember at one point my father was sort of stunned, and he referred to the period in my life as when I was drifting, when I didn't think I would go to medical school because I thought, I might pursue, actually at that point I was thinking medical journalism. But in any case, you have to listen to sort of where your heart is. But I have found global health and public service to be, as rewarding as anything I could have hoped for in a career. And I hope you'll all find career paths that are similarly gratifying for you.
Peggy, thank you for joining us. And you've been a leader over the course of my career, and with great integrity and great impact in public health. So we are really grateful for your joining us. We'll have our virtual clap for you, and thank you for taking time on an evening after a long day of Zoom calls to share your time with us. So thank you.
Thank you. Thank you. All right. Bye-bye. Good luck.